Hello, my name is Dr. Celia McIntosh, and I will be speaking today about women wounds and warning signs, the maternal stroke crisis. So, what we know is that stroke is the leading cause of death among women worldwide, and there's a rising threat during pregnancy and postpartum. Today, we'll uncover why this has been missing and what we can actually do about it. I don't have any financial disclosures. By the end of this session, participants will be able to describe at least 3 psychological changes during pregnancy, postpartum, that actually increase stroke risk, and identify a minimum of about 5 stroke warning signs using the wounds mnemonic. Analyze how racial disparities and systemic bias contribute to maternal stroke outcomes, and demonstrate the ability to apply maternal stroke warning signs in a case-based scenario of a clinical context. So we're just going to really focus on, a little bit of health equity and real world tools to essentially empower the attendees here to recognize and respond to maternal stroke. Just a little bit about me. So I have over 20 years experience as a nurse. 13 of those years I've spent working in a neuroscience department, predominantly inpatient, where I see a mixed population of patients, whether a vascular stroke, epilepsy, MS, but I do get occasionally some women that have just delivered and get called because of some post-delivery complications. And I have on multiple occasions had a positive stroke from some of these women. So I want to talk to you a little bit about a crisis hiding in plain sight. Stroke is a leading cause of maternal mortality. It's often underdiagnosed and mismanaged, especially in the postpartum period. What we know is that even in Georgia, maternal health outcomes are among the worst in the nation. Even where I live in Rochester, New York, we in Monroe County, we're doing worse than New York State, not only for maternal health, but also for infant health as well. Stroke is the 5th leading cause of death in the United States and the number one cause of long-term disability in women. Black women in Georgia are about 3 to 4 times more likely to die from stroke-related pregnancy complications than white women, and I would say that it's pretty similar across the nation. And so why do we care about that? What we know is that behind every statistic is a life lost and a family that is forever changed. Georgia's maternal stroke crisis is not just a medical emergency, it's also a call of urgent, equitable, centered action. So when we think about the mother's brain, a stroke can be a silent threat. Maternal stroke is on the rise, especially for Black and Brown women. So let's dig a little deeper here. Stroke accounts for about 6% of pregnancy-related deaths in the US between 2017 and 2019. Women are 3 times more likely to experience stroke during pregnancy or the postpartum phase compared to non-pregnant women. And half of all maternal strokes occurred after delivery, most within the first 6 weeks postpartum. So why does this happen? Stroke symptoms like fatigue, dizziness, or headaches often mimic normal postpartum recovery. And that leads to a misdiagnosis or dismissal of someone's symptoms. This silence and delay often creates a critical window of missed opportunity. We know that if someone is having a stroke, a non-pregnant individual coming into the hospital, for them even to be a candidate for any kind of clot-busting medicine or TNK or TPA, they really need to come in within typically 3 hours, but a max of 4.5. So if you have a woman that have these symptoms, that's recently after their delivery, the sooner that you can get them you can recognize the symptoms, you can get them imaging for the brain so you can figure out what is going on. And oftentimes we lose that opportunity when the symptoms are dismissed. So without quick recognition and treatment, outcomes can escalate and treatable and from treatable to tragic. Okay, so if we miss these symptoms then and these signs, then we can ultimately miss a diagnosis that could have been potentially treatable, and the outcome can be pretty tragic. This is one of the most dangerous clinical blind spots in maternal care. Stroke doesn't present like a dramatic collapse in many cases. I've had mothers present with various different symptoms. Typically, for many of my patients, they may come in with aphasia, meaning, they have some difficulty with their language center. They may have one side weakness. They may have some visual changes, but I haven't had that drastic of a change with a mom that I've taken care of. And maybe because it's not presenting as dramatic as that, it's often missed. Often it's told that maybe it's related to stress, that it's typical for the postpartum phase, and that's why this crisis keeps happening, because it's underdiagnosed and underrecognized. Not because we don't have tools, but because we don't use them fast enough to take mothers seriously. So when we think about why this is even an issue during pregnancy, pregnancy is often described as a beautiful journey, right? But physiologically, it's a storm that the brain has to weather. So let me break that down a little bit. First, we have this hemodynamic overload. During pregnancy, the blood volume increases up to about 50%. Then the heart has to work harder, which means your cardiac output rises. This means that there's more blood flowing to the brain, but the brain isn't always prepared to handle the flow. So in some women, there are extra volume, and this extra volume can lead to cerebral edema, essentially some swelling or even hemorrhage. And then second, there's hypercoagulability. Essentially, it's a natural defense mechanism that the body uses to prevent excessive bleeding after delivery. But this also increases the risk of clot formation, essentially in the brain's venous system. So then mothers can get this CVST, cerebral venous sinus thrombosis. Okay, if they have too much blood and clots backing up into their venous system. And that's why strokes, like I said, likely cause the CVST, and that rises in the postpartum period. In addition to that, your hormones surge, especially your estrogen and progesterone, and that changes how your blood vessels behave. They can cause vasospasms, or make your blood vessels more permeable, which increases the risk of both ischemic and hemorrhagic events. So basically, has a tendency to leak. Okay. So while the body is trying to protect pregnancy, it may unintentionally put the mom's brain at risk. And that's why stroke during or after pregnancy isn't just possible, it's predictable. So we know that pregnancy essentially places the body in a very complex, high demand circulatory state, and to support the growing fetus. But these have to do some adaptations that protect the pregnancy and can also strain the brain. So when we think about the different types of stroke, the number one is ischemic stroke. It's up to about 87% of the population get that. Like I said, it's the most common. Essentially, what this is that you have a clot that blocks your cerebral artery, cuts off the blood flow and the oxygen to the part of the brain. Why is this happening? Because pregnancy triggers that hypercoagulable state, which increases your clotting factors and your platelet activity. So when you have conditions like preeclampsia, gestational diabetes, and you're immobile, that increases your clot formation. These clots can also form cardioembolic So basically, you develop these clots. They're coming from your heart, which is why we say cardioembolic. It comes from the heart, travels up to the brain, and because possibly because you have something like peripartum cardiomyopathy, or maybe you're dehydrated, and they can cause a venous strain in postpartum women. So when those clots come off the heart, they can go up to your brain. You may have a variety of different symptoms which are not recognized. For a hemorrhagic stroke, it's essentially a bleeding stroke. The bleeding occurs directly into the blood tissue, the brain tissue, and the surrounding space due to rupture of the blood vessel. And when that happens, there's just a lot of damage that occurs around that area. When you have, and that usually happens if you have severe hypertension, which can happen when you have mothers that have preeclampsia or their blood pressure is not being managed correctly. They can have very severe hypertension, which leads to a potential rupture of their blood vessel, which leads to a hemorrhagic stroke. And this essentially, even with the preeclampsia and the eclampsia, it damages their blood vessels. And then you have this endothelium disruption, and fluid overload can cause the vessels to rupture as well. When we think about postpartum blood pressure, that spikes and can rupture already very friable or sensitive or stressed cerebral arteries. Okay. So when we think about the hemorrhagic stroke, it's usually caused by more of a rapid deterioration. Maternal causes, 50% of strokes are hemorrhagic and much higher than the general population. So the reason why I'm bringing that up is that when you think about this population and elevated blood pressure, if the blood pressure is spiking, this should be a cause of concern and should be monitored more frequently. And there should be signs checking of this woman more frequently, this mother more frequently, just to make sure that some of this stroke type is not occurring. When we talk about the cerebral venous sinus thrombosis, that's essentially the blood clot forms in the brain, typically in your venous sinus, preventing blood from draining. So if the blood is being prevented from draining, it's backing up. And this causes increased intracranial pressure, brain swelling, and ultimately hemorrhage. And that is a combination of things. You're hypercoagulable because of your pregnancy. You may be dehydrated. Plus, you have this venous stasis, essentially, because you're not as mobile as you normally would be from labor or bed rest. And that leads to a perfect storm. And then the venous sinus thrombosis is typically occurs in the first 6 weeks postpartum. Individuals may present with headaches, seizure, visual changes, or maybe even confusion, neck pain as well. So many hospitals should be considering this as a diagnosis, the venous sinus thrombosis, but oftentimes it's missed because of not necessarily using the specific tools for this population, or many of their complaints potentially are ignored. So just to go a little deeper in here, so when we think about why these increased stroke risk, preeclampsia and gestational hypertension can actually cause your blood pressure to rise, and then that damages your blood vessels, and then that may lead to some brain swelling. So that ultimately leads to an increased risk of hemorrhagic stroke, and this concept of PRESS. So I'll talk about that briefly as well. So one of the other things is cesarean section. You have a C-section, you're often immobile, dehydrated, you have a lot of surgical stress, and that increases your risk for the venous sinus thrombosis, the clot in the brain's venous system. In addition to that, you may have had some assistive therapy, like if a mother may have used IVF, she has a lot of hormonal shifts and fluid overload and higher chance of preeclampsia, which leads to a higher risk of clot. And when we think about infections and inflammation, things like the COVID pandemic, COVID-19, triggered vascular inflammation and clotting, and therefore increased risk of ischemia and venous strokes. Okay. So we'll talk a little bit about pre-existing conditions also increase the risk. Hypertension, like I mentioned before, it damages the blood vessels, increases the risk of bleeding strokes, also known as hemorrhagic strokes, especially with preeclampsia. When you have diabetes and obesity, that promotes inflammation. You may have some atherosclerotic disease, develop some blood clots, and then ultimately increase the risk, leading to ischemic strokes. Migraine with aura. This is associated with a lot of vascular instability and higher risk of clot formation, especially during pregnancy. When you have someone that has migraine with aura, it's been linked to 2 times higher risk of ischemic stroke, especially in young women, especially if there's other risk factors. For example, if they're combining, if they're pregnant and they have preeclampsia or they're smoking, or if they have delivered and they're in their postpartum phase and they're potentially using some oral contraceptives, that may increase their risk. And when we think about autoimmune and clotting disorders, conditions like your lupus make your blood more likely to clot, and the risk of venous sinus thrombosis and ischemic stroke also increases. So who's at risk? Any woman essentially that is pregnant up until a year is at risk, but there are specific populations that tend to be more at risk. We know that Black women had a 3 to 4 times higher risk of pregnancy-related complications and death. We know that up to 2 times higher risk of stroke when hypertensive disorders exist, like preeclampsia. And for Hispanic women, we know that they face elevated risk due to higher rates of undiagnosed diabetes and hypertension, and more likely to receive late or inadequate prenatal care. And then, of course, women over 35, there is also this idea of geriatric pregnancy, which this is called, but ultimately it's saying women over 35, you have an increased stroke risk due to vascular aging, comorbidities, and possibly pregnancy-related complications like preeclampsia and gestational diabetes. So we're kind of seeing those themes emerge. And these disparities aren't just numbers. They reflect systemic inequities in how the care is actually been delivered and who gets heard and how quickly symptoms are actually acted on. So if there's any delay in care, that is problematic. So it's not enough to know the risk. We need to change and we need to be able to respond to it to ultimately make sure that the mothers are safe. So there's a lot of other factors. When we think about social determinants of health, some individuals call it social drivers. They're essentially contributing factors. When you have social, environmental, or systemic factors, they're major contributors to maternal mortality crisis, especially for Black women. Things like not being able to access healthcare, having healthcare, but because you have a certain insurance type, many individuals may not take it. Insurance barriers. Pregnancy is still considered a pre-existing condition for some insurers. Medicaid delays, especially if this is a state that does not accept the Medicaid, for the eligibility that varies from state to state. There's a lot of red tape, and that can leave women uninsured during these critical prenatal periods. Mobility challenges, if there's public transportation that's not available, if you live in a rural area and you don't have access to, hospitals, if there's maternal deserts, that poses a risk. Women often cite that transportation insurance gaps are reasons why they're missing their prenatal care. Women without prenatal care are 3 to 4 times more likely to die during and after pregnancy. And other things like education. Black women with college degrees have higher rates of severe maternal mortality complications than their white counterparts that didn't finish high school. Higher education is not protective for Black women the way it is for white women. And even Black women with normal pre pregnancy BMI still face elevated risk. Environment and community factors, like if you have unstable housing and exposure to environmental toxins, lead, any kind of industrial waste, that can increase your risk. Community level factors like your structural racism, over policing, poverty, any kind of local policy failure, that increases the factors. Racism in healthcare, when we talk about discrimination in settings, dismissed from your symptoms are dismissed, then ultimately you're delayed in getting care, delayed diagnosis. You may be exposed to dehumanizing treatment. And some of the long-term effects of that is that essentially the trust is eroded. You don't want to go to these providers if they're treating you suboptimal. And many may avoid the healthcare system until their symptoms get severe and worse. Maybe there's some age-related risk. We know that young adults under the age of 20 are at the highest risk of fatal pregnancy complications. Age related to risk is compounded by race, access, and other social economic factors. And essentially, the final takeaway is that maternal health outcomes are shaped by more by the system and structures than by personal choice. Until we address racism, inequity, social determinants, the maternal mortality crisis still exists. And like I said, especially for Black women, it will persist as well. But we know the nation overall is not doing well with maternal health. So there's this concept called weathering and how racism ages the body. And when we think about weathering, it's not just a metaphor, it's a measurable biological response to the lived experience of chronic stress. This was coined by Arlene Geronimus, and she actually coined this, and it was essentially described as psychological toll of chronic exposure to racism and structural inequity. And it really leads to premature biological aging and higher risk of chronic disease in Black populations. So essentially the ends of your telomeres, you see those black tips right there, they essentially, with chronic stress and chronic racism, they start shrinking. So they essentially start shrinking, and because of that, overall, your lifespan becomes shorter. So the chronic consequence here is if Black individuals exposed to chronic racism and stress have disproportionate high rates of heart disease, stroke, diabetes, cancer. And we know that these outcomes are not genetic, they're socially induced and systematically sustained. So, like I said, these telomeres, because of the chronic stress, they shorten. And when the chronic stress comes in, it actually accumulates and accelerates the process, leading to early cell death, tissue breakdown, organ dysfunction, and essentially that allostatic load where you get the wear and tear. And then essentially, like I said, there's a cumulative burden over time. And then that ultimately leads to shorter lifespan. So other factors that affect mom is just, like I said, we've spoken just briefly about it, but dismissing the symptoms. Many think that, okay, well, the headaches, the mood swings, maybe the visual changes or the fatigue is all normal part of the delivery. And when the complaints come in, they're not investigated like they should thoroughly, even though we know that this population is at high risk for stroke. Many organizations are not equipped to do adequate assessments. So when we talk a little bit about the other medical factors driving maternal mortality in the United States, here are some. 65% of pregnancy-related deaths occur within the first week postpartum. And that's a real critical period that demands better follow-up and support after delivery. Other than that, we know that C-sections are a major rate, and over 30% of C-sections. So the national C-section rate is over 30%. And with that, higher rates of, in fact, higher rates of C-section lead to higher rates of complications and potential infection and hemorrhage and ultimately longer recovery time. So less than 10 prenatal visits is also associated with increased maternal mortality, cardiovascular disease, leading cause of maternal deaths, responsible for over 1 in 3. So when we think about cardiomyopathy, when you think about hemorrhage here, hemorrhage is triggered from a lot of the hypertensive disorders. When we think about infection, I mentioned that from the C-sections, pregnancy, you're in a very hypercoagulable state, so you're more prone to clotting. So that can lead to embolus, whether it's a DVT or PE or ischemic strokes. And then of course you can get hemorrhaging, severe bleeding during or after delivery. You can have the placenta increta, accreta, and precreta. So you can have a uterine rupture and ectopic pregnancy as well. So there's many different factors that occur during pregnancy. The HELLP syndrome, severe form of preeclampsia that also causes liver damage, low platelet counts. All of this can lead to potential seizure, stroke, organ failure, sepsis, infection of the amniotic fluid. So there's just a multifactorial thing that happens medically when mothers are giving birth or pregnant. And of course, not to mention, postpartum depression, untreated postpartum depression can also lead to suicidal ideation and suicide. So we have to also make sure that we're paying attention to those issues. So the kicker is that 80% of deaths they're preventable. They're due to preventable causes. So this is important because there's something that we can do about it. But some of the issues is that many of the mothers state that they don't feel like they're listened to. And specifically for Black mothers, they say that they don't feel heard, they're invisible, they're marginalized, the care is delayed, they don't get papers at discharge with those instructions. At least that's what I've heard in my organization, that, when they're putting on their call lights, they're not getting the same attention. They don't get the same prenatal paperwork of what to expect in each trimester. And at discharge, they're not getting adequate information about follow-up. And we know that that's really important. So they don't feel empowered. So when we talk about these unique issues, we know that it's a common thread. Okay, we know that oftentimes women feel ignored, and this distrust in the healthcare system isn't imagined, it's earned through repeated harm, delayed treatment, and clinical bias. So, but the cost of the distrust is devastating, and it leads to fewer prenatal visits, delayed emergency care, higher rates of low birth weight, premature birth, and maternal death. So the consequences is severe. So that's why I created the wounds mnemonic, really as a tool for every provider and family member to be able to recognize some of these stroke symptoms early. So the wounds mnemonic is essentially a tool to identify maternal stroke warning signs. And in stroke, we typically have an NIH stroke scale, but I wanted to kind of create something that would help, you identify some of the symptoms quickly. So I'll break these down a little bit more. But for the sake of this slide, W is for weakness. O is essentially that headache. It's the headache out of proportion. Are there unusual behaviors and confusion? Numbness, facial droop? Is there dizziness? Is the gait off? Is there slurred speech or are there vision issues? These are some of the signs that if we're using a scale, a stroke scale, that we would be assessing these. So is there weakness on one side? Does the arm or leg suddenly feel heavy or limp? Is the grip weak? Oftentimes, even if it's subtle, if there's been a delivery or anything, we need to investigate those because we know that we're in a critical window and we know that pregnancy in itself increases, it's not necessarily protective in a way, and it can do harm to the mother's brain. So if there's any numbness, any weakness, drooping of that arm, face, leg, weak grip, difficulty with dexterity in terms of the fingers, difficulty holding on to things where, like a phone, where they didn't have an issue before, difficulty holding the bottle, putting the bottle together, anything like that in that moment, we need to investigate. Oh, is the headache out of proportion? Is it sudden? Is it severe? Is it in a location that's different? If this is an individual that has headaches, is it different from their typical headache? Those are some of the things that you want to investigate. Yes, you may normally have a headache, but what's the quality? Has anything changed about it? Is it thunderclap, like a lightning strike? Does it feel like someone hit you in the head with a brick? Where is the location of the headache? Oftentimes, headaches are not, when we talk about strokes, they're not necessarily painful. From my experience, from what I've heard my patients, unless it's a bleed or usually in the back of the head. I hear a lot of patients complain about headache if the stroke is in the back of their head. So where is the headache? What's the quality? If there's someone that typically gets headaches, see if it's different from their normal one. If it's not, and it's come on sudden, severe, it needs to be investigated. Is there vomiting? Do they feel very nauseous? Because sometimes depending on where the lesion is, you can get those symptoms. Now, do they have any unusual behavior or confusion? Do they seem disoriented? Are you asking them questions and they seem very out of it? Are they having trouble with their words? They're having trouble remembering things. Are they having difficulty following command they wouldn't have before? Does it seem like they're not really recognizing maybe one side of their body? How is their personality? Has this shifted since you've had them? Has their memory changed? Numbness or facial droop? Are they complaining about tingling on any area of their face? Are they complaining of tongue numbness or anything in that area? And it doesn't have to be the whole face. There could be parts of the face that they're complaining about. So being able to kind of differentiate where is the location that they're complaining about. Of course, like, is there any facial asymmetry? Does one of their side of their face droop? Is one of their eyelid a little bit wider than the other one? Or is it drooping? You want to basically note that. Are they having trouble articulating their words? Does their words seem slurred because they're having this facial weakness? Are they dizzy? Are they feeling like the room is spinning? Do they feel like their balance is off? Are they leaning to one side or the other when they're getting up and going to the bathroom? Do they complain of vertigo or feeling like they're going to pass out? What do they have any balance issues? Do they feel like they need to lay down because when they sit up, the room is fitting? Those are some of the things, if this is changing, needs to be investigated. And of course, here, slurred speech. Do they have trouble articulating their words? Other things, not really specifically related to slurred speech, but towards their language, are they not getting their words out? Do they have aphasia? Does it seem like they are making errors when they're speaking? Are they substituting words? That would cue you into maybe they're having elements of aphasia. So that would be one of the things that you would also be a cause of concern. Vision changes. Are they saying that they're missing parts of their vision? Maybe they have double vision. Depending on where the lesion is, sometimes double vision can cue us into a brainstem stroke. So you want to make sure that you're investigating some of these things. Is it in one eye? Is it both eyes? Are you missing the peripheral vision? You want to do more investigation to figure out where this could localize to. And when we think about red flags in preeclampsia, like I said, severe headache, maybe some visual changes, maybe some right upper quadrant pain. Some may come in with seizures or edema or strokes, but you'd have to get some kind of imaging to see what's going on in the brain. So when we think about the postpartum stroke, there's a danger window. 50% of maternal strokes occur in the first 6 weeks postpartum. And that risk remains elevated for 12 weeks. And commonly misdiagnosed due to fatigue, depression, or sleep deprivation. Stroke isn't over once the baby's delivered. We often say that we should have a fourth trimester. When we think about, I'll show you a graph later, but that continuum of pregnancy actually goes up to a year. So I'll discuss that a little bit more. One of the major issues is the diagnostic gap and the delays. Like I said, when you're, not thinking that, maybe this is supposed to be a young woman, uh, you know, she's, some people look at age and because you're a certain age, they put you in a category that you're not at risk for stroke. And we can't think like that, because what we know about pregnancy is that it creates a lot of changes within the body, makes you hypercoagulable. So you are at risk for that year. So symptoms, may be blamed on your mood, fatigue, normal complication after stroke, or excuse me, normal complication after pregnancy. So they won't attribute it to a stroke. Limited postpartum imaging protocols. I know in our facility, we will get the MRIs, but in some organizations, they're not comfortable with that. And then, of course, like I said, not considered in postpartum women under 40 in some locations. So that's not a case in our hospital. If you know about the symptoms, you make neurology or a provider aware of the symptoms, and then they can go down the road of investigating what else could be going on, so you can decrease some of those diagnostic delays. We know that, I mentioned this already, Georgia consistently ranks in the top 5 states for maternal mortality. Maternal stroke accounts for a significant portion of death because it's underdiagnosed and underrecognized. And many maternal strokes occur after discharge. So the mothers have to be educated on what to look for. Okay. There's a high prevalence of hypertensive disorders in pregnancy. And then, of course, gaps in the follow-up and the imaging access. So if we have this 32-year-old female that she's postpartum, she came in, she has a headache, she's confused, her balance is off, but she was sent home because they figured, well, it's just a postpartum migraine. There was no imaging done at that time. And she came back within 24 hours and her symptoms were worse. And actually, she returned with a seizure, and that cued them in to do brain imaging. And what they found after multiple tests was that she had a cerebral venous sinus thrombosis. So she were hypercoagulable after her pregnancy, and she ended up with a clot in the venous system. So while it's rare, once we start hearing the complaints, headache, confusion, imbalance, all of these things were under that wound's demonic. It's a change in her behavior, and they should have been investigated. So prevention really starts early. If we screen better, we save better. Stroke education should start during the perinatal visits. We need to really educate about what are the signs, not after the symptoms appear. And then, of course, monitor the blood pressure closely during pregnancy, because we know that 50%, you're 50% more likely to have higher rates of blood pressure in your pregnancy. And here, when we talk about death happens up to a year after delivery, once you become pregnant, you're at 31% risk of having a pregnancy-related complication. During your pregnancy and after delivery up to 1 week, that jumps up to 36%. And from there, once you deliver, a week after you deliver up to a year, that percentage still stays at 33%. So you're still up to 1 year, 33% at risk to have a pregnancy-related complications. So we really need mothers to be educated about these potential risk factors and what to look for. So what are the role of providers? Essentially create and follow standardized protocols for stroke. If they don't exist in your organization, that is something that you need to challenge leadership about, because we know cardiac disease, hypercoagulability, all of these things, hemorrhagic stroke, ischemic stroke can happen, cardiovascular disease, all these things set women up for complications. And so we need to have a rapid imaging if needed. We need to take the symptoms seriously. We need to collaborate with the OBGYN, neurology, emergency departments. We need to have protocols so that we're able to activate something for moms if their symptoms change and they have one of these stroke symptoms. Advocacy starts at the bedside. You have to listen to patients. That's one of the most common complaints, that patients are not listened to. Now, while this happens predominantly in Black women, I could tell you that across the board, I've heard that women are not listened to. Anytime they have pregnancy-related complaints, it leads to complications because they're not listened to. So, like I said, it definitely happens more so in Black women, but this is a major thing, listening to your patients. They know their body more than we do. Document the symptoms carefully so that if something changes when they're not in your care, you can compare the baseline to the current. And that way you have an objective measure to look at. Escalate the concerns, even if the vital signs are stable. If there's a concern, if there's a change, they need to be escalated so that we're in that time window to do something about the stroke symptoms. Equity means action. Black women's symptoms are more likely to be dismissed. They receive fewer neural consults and delayed imaging. So culturally competent care and anti-bias training, it's essential. We know that different facilities are going to be doing different things, but we know that the literature suggests that it's an essential component to improve patient outcomes. It's not just medical, it's moral. If the care is not equitable, then it's not excellent, okay? And you run the risk of having complications. So in terms of extending postpartum care, advocating for 12-month postpartum Medicaid coverage, scheduling neural follow-ups after hypertensive pregnancy, especially if they've had a change in their symptoms. Essentially, integrating stroke symptoms, educating moms about what those are. And then, of course, educating them about the Hear Her campaign, which is a campaign. It's actually a public health initiative by the Center for Disease Control and Prevention. And it was aimed to raise awareness about maternal warning signs and the importance of listening to pregnant and postpartum women when they say something doesn't feel right. We know that, women, like I said, have a lot of pregnancy related complications. 80% of them are preventable, but we have to listen. And this Hear Her campaign really has a list of symptoms, and it has a form also to really help empower the mothers when they're talking to providers in ways of how to ask the questions. So community education matters. We need to educate doulas. We need to advocate for better funding and reimbursement for doulas, and midwives and community health workers. We also need to use social media and different mechanisms to increase the education around spreading stroke awareness. We need to create materials that reflect diverse populations. And in terms of discharge, we need to reimagine what that looks like. Maybe having some of these wounds, mnemonic, different signs of stroke in the postpartum package, not even the postpartum, in the prenatal, you know, package, because we need mothers to understand that this is a very real consequence of pregnancy, or, a possible complication of pregnancy from the time she gets pregnant, so she is aware of what to look for. So from the time she gets pregnant and comes in with that first appointment, these information needs to be handed to her so she knows what to look for. And then, of course, ensure the families know what to look for, because if something happens, they are her eyes and ears. So they can contact medical professionals, ambulance if needed. So the family also needs to be a part of the conversation. And then, of course, include caregivers in this teaching. Mothers are not the only ones noticing these signs. It really takes a village. So when we think about this, stroke is a public health issue. We know that maternal stroke intersects with other issues like housing, access, food insecurity, and racism. And public health must include neurovascular health. We won't solve stroke in a silo. We know that health justice means maternal brain health too. So when we talk about a call to action, we need to RPR, recognize, protect, and respond. And when I say recognize, we need to know the signs from the wound mnemonic. Okay, we need to educate everyone, not just providers. We need to include the family and the mother as well. When we talk about protect, we need to address racial inequities, support postpartum coverage, embed stroke education in perinatal systems. And lastly, here, we need to respond. We need to build responsive protocols. If they already exist, look at them, evaluate them, understand why they're not working. And they may need to be updated or discontinued. And we just need to see why they're not working if you have existing protocols in place. Cut imaging delays. Okay. As soon as mothers are complaining about these symptoms, they need to be investigated, because we know that they are deeply at risk. Demand interdisciplinary teamwork, because even if you have the neurologist on board and the OBGYN on board, maybe you have pushback from the radiologist that doesn't want to do the imaging. So, so you really need to have some kind of interdisciplinary teamwork and maybe collaborative meetings to make sure that they have protocols that they can expedite when something like this happens. Birthing life should never cost a mother her own. So like I said, just be really being able to recognize these symptoms will help the mother get to, have a healthy baby and be healthy herself to take care of her family. And these are my references. And here's my contact information. I want to thank you for attending the conference today. It's been a pleasure speaking with you.